She's a pediatric otolaryngologist with Norton Children's ENT and audiology. Dr. Chandran completed her medical school and residency training in otolaryngology, head and neck surgery at the University of Louisville School of Medicine. She then completed a fellowship in laryngology, care of the professional voice at Drexel University College of Medicine in Philadelphia. Dr. Chandran also completed a fellowship training in pediatric otolaryngology at Alfred Fred DuPont Nemours Children's Clinic in Wilmington, Delaware. A lot of great training places. Thank you for being with us today. I think your topic is tongue and lip ties. I'll let you get started. Thanks.
Thanks, Dr. Evans. Thank you, everyone. It's a pleasure to talk to you today. It's really interesting. You know, my background has kind of made me one of the few people in the state, maybe even in the country, that has cross-training in both pediatrics and adult airway and airway issue. And that includes speech, voice, swallowing. And so I think this topic of tongue tie has really kind of gained popularity over the last 20 years. And so it is one of the most simple things perhaps to consider, but there actually is a lot to talk about. So I'm going to share my screen here. Hopefully this is going to work for us. Okay, can everyone see that? Okay, so tongue tie, what's the talk all about? I have no financial or commercial disclosures. And like I said, tongue tie has emerged over the last 20 or 30 years as a potential source of feeding difficulties and possibly even speech difficulties. And there's a lot of controversy, confusion, misunderstanding about what the role of a tongue tie plays in most importantly, newborn feeding, but there's also a lot of questions about what implications it will have as a child grows, and will it affect their feeding solid foods or speech or dentition. And so today I just kind of wanted to talk about some of the recent data that's emerged over anterior tongue tie, which is kind of the common tongue tie that everyone knows about, but also the newer phenomenon of posterior tongue tie, and really kind of talk about what the literature says about it. You know, there's been a lot of cross-disciplinary discussion and interest in tongue tie, not only from ENTs and neonatologists, but also from dentists when it comes to dental issues or even sleep apnea. And so at the end, hopefully you'll be able to tell the differences between tongue tie and if or what difference it plays in feeding, and what the evolution of doing what's called a frenulectomy, or kind of releasing that tongue tie, what kind of impact that has on a child as they grow. Yeah, that's kind of what the outcome is. Hopefully everybody will get a better understanding. So the official name for tongue tie is ankylosing. It is basically a congenital attachment of the lingual frenulum that limits the tongue mobility. It results from a lack of apoptosis from the floor of the mouth and the tongue. And so it can result in various degrees of attachment of the tongue to either the gum anteriorly or the gingiva anteriorly, or the actual floor of the mouth. And originally people would not really classify ankylosing, but as more studies and more people kind of decided to look more into it, they realized that there was different looks to it. And so there's been various classification systems that have been developed. They're not all consistent. Some of them are based on just anatomy and where this tie is attached to the tongue, or where the frenum is attached to the tongue. And then some of the classification systems, like the Hasselbacher system is more on function of the tongue. Because of the variability in diagnosis and really understanding what tongue tie is, it's been suggested there's between a 0.2 and a 12% incidence of infants being affected by tongue tie. And what does affected mean? Does it mean that they just have it and we're waiting to see if it has an effect on feeding? Or are we doing kind of a retrospective look and saying, hey, this kid or this 2-day-old has feeding problems. Let's look and see if they have a tongue tie. Well, maybe they have a tongue tie because they have feeding problems. So I think this huge variability on chicken egg scenario, it creates this wide variation in what constitutes a tongue tie. Most of the literature is for the anterior tongue tie, and I'll get to what anterior tongue tie means, but it's kind of that common one that most pediatricians or neonatologists are able to see when the baby cries or tries to feed, where there's this thin band that goes to the tip of the tongue. That is the anterior tongue tie, and it's thought to have a male predominance of almost 3-to-1. When we talk about the posterior tongue tie, which, like I said, has gained some press here lately in the last 10 years or so, maybe 20 years, that tends to have more of a female predominance. There's sometimes an association of an upper lip or a maxillary frenum, and again, that is between the upper lip and the gum line, and there is concern about that and feeding and maybe dentition as well. Most cases are considered to be sporadic, but people are trying to find out if there are some familial or genetic links. And there's some talk that maybe it may be X-linked or autosomal dominant, especially maybe given the male predominance. And some gene associations are being investigated, but there is just a lot of genetic heterogeneity and phenotypic heterogeneity. So this is still very early on in its development. And, you know, all of this comes to say, what is the impact or importance of tongue tie? And really the primary implication would be for breastfeeding and speech. And so tongue tie had been noted early on in, and it really kind of gained some interest in the 1600s when King Louis VIII, who's pictured here, had to have his tongue tied 3 times. So he could breastfeed appropriately. And then in the 1900s, midwives just started doing tongue tie release shortly after birth. And so, you know, it kind of was this thing that people would notice if there was a problem with feeding and would do as needed. And then in the 1940s and the 1950s, it really did not happen. It really, people did not do or did not even consider, because bottle feeding became very popular. And so there was kind of this lack of association with tongue tie and feeding at all. But then again, in the 1970s, and then especially in the 1990s, breastfeeding became more popular, and there was more data on breastfeeding, and so it was really encouraged. And so with that, tongue tie diagnosis and management became more popular. In a study of the KID database between 1997 and 2012, there was an 834% increase in the diagnosis and management of tongue tie. So that's pretty significant over that time span. So like I said, over the last 20 years, it really has become this phenomenon that has become in vogue, if you will. It's controversial though, because there's no standardization, even though there's all these classification systems. Just like any kind of exam, you actually need to perform the exam a certain way to identify it. And there definitely is some subjectivity to it. And the data often looks at things retrospectively. You've got a 3-day-old that's having trouble feeding. And so one of the easiest things to consider would be, is there a tongue tie? And one of the easiest things to consider releasing and doing a procedure on would be a tongue tie. Very similar to circumcision. It can be done right there in the NICU or in the nursery. So what are some of the things that we look for, though, anatomically? So we look at the length of the frenulum. Again, that's very subjective. There's no good data to say that if it's 1 millimeter or 2 millimeters, or if there's no protrusion past the lip, everyone will say, oh, well, he can protrude his tongue past the lip. There's not a tongue tie. But now we've realized that as we look at the depth of the attachment, the amount of tongue movement can certainly be affected. It's not just protrusion, it's the side to side movement, it's the lifting and raising it to the roof of the tongue. If you think about when you eat peanut butter, a lot of times it'll get stuck in the back part adjacent to your molar. You take your tongue all the way back there and you'll sweep it forward to be able to swallow it. And so it is kind of noted that some children that have more severe types of tongue tie are not able to do that. And that inherently has some dental hygiene issues as well. Again, a lot of people will talk about just sticking the tongue out and is there this heart-shaped or cup-shaped tongue, and that is one of the diagnostic criteria, but a lot of children who have a more posterior tongue tie won't have the heart-shaped tongue. It's more of a mobility. And so then we look to actually palpate rather than just look for the frenulum and see if we can feel like there's any tethering or any restriction in the way that the tongue is able to move, especially laterally. And then we obviously want to talk to the mom and hear what she has to say about her own symptoms and the baby's symptoms. And so a lot of times moms will talk about having just difficult, painful breastfeeding in which the baby is not able to latch very well. And that's causing their own problems with their breast and discomfort, such as plugged ducts, cracked, blistered nipples. They're nursing all day, all night because they feel like their baby just isn't getting enough food in any one given feed. They will have mastitis and sometimes they'll have compromised milk supply and the milk just doesn't come in because the baby's not able to feed appropriately. The baby symptoms, I think are really interesting because it's just not this lack of ability to latch or feed. As I've talked to more and more patients, there is some consistency in what parents are telling me, but it's usually a baby that has difficulty latching. There's a lot of manipulation at the front end of feeding and trying to get the baby to latch appropriately, but there's often a lot of leakage because there's not a good seal. And then they can hear this clicking sound, which then correlates to a lot of air intake and a lot of gas, air intake and a lot of gassiness or fussiness. They feel like the babies are feeding continually, even more than any newborn would or any new parent would say. And there's poor weight gain and sometimes there's even choking and frequent stopping to just get a break. And so when I hear any combination of these things, I am more prompted to look for a tongue tie, even though it is part of my routine head and neck examination. I definitely do look for some of these consistent things that parents are telling me about feeding. So this is one of the diagnostic criteria that I use. I felt like it was pretty representative. I wasn't going to go through all of them. Like I said, there's like 5 or 6 different types. And this is the type 1, which is your classic anterior, where the frenulum is clearly attached to the tip of the tongue. And then as we move on to the type 2 over here, there's about a 2 to 4 clearance anteriorly, but otherwise it's attached, 2 to 4 millimeter clearance anteriorly, but otherwise it's attached pretty firmly. And then, type 3 is even a little further back, but this type 4 is the one that's just a little bit newer, maybe some confusion, and in my mind, a little bit overdiagnosed because people just don't really know how to look for it, and they feel like there must be a tongue tie because there's feeding issues. And basically it's considered to be submucosal, where there's mucosal hooding over the frenulum. So it's not this clear band that you see in the first 2, definitely maybe even the 3rd, but it's something in which you would only be able to diagnose if you were to palpate or use one of those groove directors, which is a metallic instrument that we use to actually perform a frenulectomy. There's also the upper lip tie. So what we're looking at here is the baby's tongue, and this is the upper gum, the gingiva here. And this is a type 1 where it's really not significant. And then again, various levels of thickness and attachment of the lip to the gum. The inherent concern with an upper lip tie is that there's a lack of the baby's lip to flange appropriately over the nipple. So there's not this good seal over the breast nipple. And so that causes some leakage and some tiring out. I personally think, all children have a frenum, and, some people are concerned about the gap. When I've talked to dentists, they actually think that the gap in between teeth is good when it's their baby teeth. And so again, most of the classifications and the indications for doing anything about the tongue tie would be, in my mind, for feeding, and we'll talk a little bit more about that, and that's what raises some of the controversy. So this is kind of what I was talking about in terms of diagnosing. That the literature states that there's a kind of proper way to position the baby and position the clinician. So the clinician should actually be behind the baby. The baby would be laying on the mother's lap with the head on the knees almost. And then the physician in front of the mom. And then you're taking your hands almost posteriorly and then identifying where there's a frenum. And in doing this, there's a, I always say I can make a frenum if I do that, to be honest, and when I look through the literature, almost 60% of babies, when they were, having the examination done, were found to have a posterior frenum. I mean, it tends to be a really soft tongue with really great mobility. And I'm like, no, there's nothing here, but I can make a frenum if I do this. And so this is where some of the diagnostic criteria from symptoms and some of the other signs of feeding come into play. And then you correlate the two in determining how you're going to treat this. So there's several ways to do the procedure. And again, this has kind of emerged over the last 10 years in particular about, the depth of the incision and really correlating that with anterior versus posterior type 1 to type 4. The most common is just a simple frenulectomy or frenotomy, where you cut that band. A lot of times it's done in the office. There's some controversy over using lidocaine just because of some of the contraindications in infants. And so glucose water or sucrose water is typically just utilized. And then we'll use what's called a tongue groove director to kind of isolate that frenulum, create a hemostatic plane by clamping it. And then just, you can use a scissor, a bovie, a laser. You can use any number of ways. And there's literature of pros and cons in any which way. If I'm in the office, I tend to just use scissors because it's easy. If there's any bleeding, I'll use kind of a chemical cautery. But typically, if it's just the band, there's not much bleeding to be encountered. There's a lot of dentists that will use a laser. They have office lasers. And so, some people think the laser is better, I guess, because it's a laser, but I feel like that about many things. I think there are many ways to skin a cat, I guess. And so I tend to keep it pretty simple because I've got a moving baby in the office. There are times in older children where I will use some general anesthetic if I just feel like I'm not going to get an adequate release, and I'll end up having to redo it. Sometimes I just tell the parents it might be worth a 3-minute general anesthetic just to make sure that I'm pretty comprehensive in the release of it. And then, really kind of determining what the posterior limit of your incision is. And I tend to go down to the anterior genoglossus muscle. So I tend to go down to the level of the muscle, so there's less chance of that scarring and reattaching. Sometimes I'll stitch or put a stitch in there to kind of keep it from scarring or reattaching. And then sometimes they're more comprehensive, or like plastic surgery techniques that you can do to also prevent it from reattaching. So this is basically where the surgical cut is made. And then this is a picture kind of showing a deeper incision where I went down to the muscle here. And you want to end up with this kind of elliptical look to it. And then I'm putting a stitch. So here's the ellipse again, and then I'm putting a stitch here to try to help prevent some scarring. And this is typically when it's a posterior or a deeper tethered tongue, to really try to get it to release and not reattach, so the baby can get better functionality. So overall, the procedure itself, is very low risk in my mind. I mean, there's some bleeding, and sometimes, especially when we do the upper lip, there's bleeding, but it can be controlled in most situations. And there have been isolated case reports of some complications, including infection of the submandibular ducts, because you have to be careful to not injure that, or like I said, or hemorrhage. There are anesthetic concerns, of course. But some of the other things to consider is, and it's hard to tell in a newborn, but are there going to be some other comorbid conditions that would prevent the kid from feeding well? And that's hard to tell in a 3-day-old, easier to tell in maybe a 12-month-old. But, sometimes there's concerns of aversion of food because you've manipulated the tissue there and causes pain. And, that pain for a few days can significantly cause some children to backtrack. And then, the tongue does come forward, and that attachment does play a role in keeping the tongue forward. And in some cases where you're worried about posterior displacement of the tongue and airway collapse, you really should be cautious about releasing that. And a typical example would be Pierre Robin, a child that has retrognathia, posterior tongue placement. I'm a little bit hesitant when we already know there may be an airway issue to release the tongue and allow it to fall back a little bit more, because it does not have that anterior attachment. So what do the studies show? I will say anecdotally, even though I'm not always sure that the baby needs it, but you go by the advice of the speech pathologist, the lactation consultant, and just listening to the parents and how desperate they are, I will say more often than not, parents are happy and babies feed better. I think there's very few times where I've had someone say there's been no impact, which is interesting to me. And the literature corroborates that. There's, I think, inherent biases towards treatment because it is such a simple, low-risk procedure. And then we, again, make this retrospective association of the symptoms, and that may also overestimate the benefit and even the diagnosis of tongue tie. And like I said, most studies indicate improvement. So when there's been a type 1, type 2, just the anterior tie, maternal pain in a study in 2013 showed 100% improvement. And when it was a posterior tongue tie, a 50% improvement. And then similarly with the latch, with the anterior tongue tie, 79% improvement in latch, and with the posterior, 63%. So, I mean, it's significant. And very, very few times we have to do a revision where we have to go back and try to do it again. And again, I look to the parents, speech pathologists, lactation consultants, and if they still feel like there's some restriction, I may consider doing it again. There's less data on speech improvement in general. So most of the data is on early breastfeeding in the newborn stage. There are several anecdotal reports of older children in feeding because they do well initially, but then as we start to introduce solid foods and they can't move their mouth side to side, then we start, we're starting to study that as well. But it really is more of a feeding phenomenon that we're looking at, and then we'll just have to do more studies on the speech and dental implications. So usually the result is immediate, and there continues to be improvement over the course of a month, especially if speech pathology and lactation consultants, sometimes there are chiropractors that get involved in the postoperative care to help do some stretching exercises. And so, like I said before, there's limited data on speech, and just the data is so skewed. Even in my own practice, because if a patient comes in with concerns and there's no other contraindication, it's a relatively simple procedure that has a very low side effect profile. I think, with this emergence, though, of looking for a quick answer to take care of a feeding problem, and with the results being so promising in the data and both anecdotally in my practice, I think we really need to take a step back, though, because, especially practices in a tertiary care center where we are seeing very medically complex kids, that tongue tie is not the answer for all feeding problems. You really have to consider other comorbid and developmental conditions, and that a child coming in for a feeding problem and a referral for a tongue tie release, I never just say, oh, it's going to be a tongue tie release, this is a quick and easy consult. Like, I really get into what's going on with the feeding, and I'm going to say, very often I'm uncovering other things that should be considered. And, for instance, we should be getting a swallow study to consider aspiration. Is there aversion going on in general? Are there other psychological issues? Is there choking and gagging? Are there esophageal issues? Is there something, upper aerodigestive, from a pulmonary gastrointestinal standpoint? And, especially if they have developmental delays, I really kind of go into other anatomic considerations and other functional considerations. And that's where I'm not quick to jump to the tongue tie, because all said and done, it is a procedure, and it is something that, can inflict several days of recovery. And so, and it would be a big miss if a child came in and was aspirating and I just thought it was tongue tie. So I really kind of go into a deeper dive in all patients that come in for feeding, and kind of really have to consider everything that could be going on. And then, by process of exclusion, then I would say, yeah, we can do the tongue tie release. So again, I think just because there are such good results, and just because, subjectively we can find a frenulum in almost every kid, there really is this potential for overdiagnosis and overcausation of the tongue tie as being the cause of any kind of feeding difficulty. And more importantly, I think because we don't know what the speech implications are, I think it's really important when a parent comes in and says, my child has a tongue tie. Someone told me my child has a tongue tie. He's feeding great. He's gaining weight. I have no pain, but I'm worried about what his speech will be when he's 2 years old. That is not a good indication to do a tongue tie release, because we have no good data and we have no control studies that tell us that if we don't release a tongue tie, this is what happens. If we do release a tongue tie, this is what happens. So I think we really need to shift to education on the part of the parents and other clinicians. And in New Zealand, they actually instituted a program of educating parents and helping guide them through feeding programs with different nipples. And it may be a little bit laborious for such a simple procedure. And that's kind of what we need to weigh, just the time and the labor and the costs of all of that versus doing a frenulectomy. But all said and done, it is a surgical procedure that can cause some scarring and has a potential for some sort of, side effect or complication. And in New Zealand, they instituted this education program with feeding consultants and alternative methods of feeding that really helped work with parents. And they had a 20% rate of frenulectomy, a decrease in frenulectomy. And then I found this algorithm, which could kind of help us decide which kids would benefit. And really, very simply speaking, if the child is, if we're able to perform an assessment of the anatomy and function of the tongue, and it looks like there's ankyloglossia and breastfeeding difficulty, and they've got a type 1 or a restriction in tongue movement, then yes, go ahead and do the frenulectomy. However, if there's any kind of craniofacial or other medical contraindications, then I think we should initially go down a different pathway. I have a couple videos here. I know it's 9 o'clock and I want to leave time for questions, but this is kind of a baby that has some restriction. He's spitting out his avocado. He's just not loving it. You can see he's choking, he's gagging. He's an otherwise healthy kid that's been working with the feeding therapist for quite a bit of time. He's got stuff all over. They've got to use this mesh thing. He then had the posterior tongue tie release, and now he's just picking it up and not struggling at all. Seems to kind of love his life, love his avocado. No choking. and he's moving the avocado all over the, his mouth. And then this lastly is a kid kind of just demonstrating some of the lateral movement issues. Before he couldn't do it, she's placing it very posteriorly there in the sulcus there, and he's able to move his tongue. Whereas before he couldn't. I'm sorry, I didn't have the before that was this clear. So, but really kind of getting that movement. So those are some of the movements that are kind of important to look at. So in conclusion, I think that identifying and recognizing that ankylosing can have breastfeeding implications, and using a multidisciplinary approach and hearing what your speech pathologists and lactation consultants have to say are really important, as well as the parents. And just really consider the appropriate candidacy, so we're really making a difference in these kids' lives and not overdoing the procedure. I think it's really important to do that. And there can be favorable effects, but we just need to make sure it's for the right indication. So thank you very much.
Saying that you need to let me.
Do you want me to answer some of these questions?
Sure, thank you. Once again, we're having some Wi-Fi
that's okay.
issues here. No, thank you. Great talk, very practical. Being an OBGYN, I certainly heard many of those questions and comments from parents over the years. One of the questions is there a correlation between folic acid intake of the mother and the baby having some type of an oral restriction?
So they're looking into that. I saw some of the studies. There's not really good data on that, unfortunately. That there really is not good data, and so I can't really comment yes or no. I think obviously we want them to take it for other reasons, but I think that it's just so variable, the data on that.
Yeah, absolutely. Yeah, definitely want the moms taking the folic acid.
Yeah.
So is there an upper age limit for tongue tie releases?
So no.
Okay.
Interestingly, I have an adult practice as well. And some of the speech pathologists at U of L were like, this 28-year-old has never been able to get peanut butter out of the back of his mouth or from the really, and by the end of the day, he's got a really highly vocally demanding job. He is fatigued at the end of the day. So I do frenulectomies on adults, and there's a growing body of literature and indications, and sometimes I'm just a technician, and there's this parallel body of literature for some craniosacral, for some obstructive sleep apnea, for migraines, and some of my partners look at me, and in that case, I tell patients, I know how to do it. It's simple. Like I said, if you've tried and exhausted everything and you want to go through this, let's do it. And there are patients that think their migraines get better, that with this 28-year-old, he could swallow and speak. He was very happy after I did it. So the answer is no.
Okay. That's a great question. Thank you. One last question. I work closely with lactation consultants, but many times they are not considered full team members, especially inpatient. How valid, let's see, it just jumped. Do you have the question? It just released. I'm sorry. Anyhow, if you don't mind just commenting a little bit about lactation consultants in the hospital.
I do. I value what they say, especially speech pathologists. And that's one of the things I may not have stressed enough. And I wanted to really, it's a multidisciplinary, cross-disciplinary, I like to hear from speech. And so if a 6-month-old comes in and is gaining weight and mom is just like, I'm not sure why they're not taking solid foods, or especially if there's a 3-year-old that comes in and just started speech therapy, I tell them to do 6 months of speech with the thought of maybe a tongue tie in mind. And I really value what the speech therapists, because they have different ways of evaluating the functional component of it over the course of time, over an hour session with the child, whereas I'm just coming in. So I think the lactation consultants and the speech pathologists do play a valuable role, because they certainly spend more time with the patient and have a different perspective than I do.
Excellent. Thank you. We're actually getting